Welcome to part 6 of respiratory. We are going to focus on tuberculosis and valley fever. Tuberculosis is caused by Mycobacterium tuberculosis bacillus. It affects about 10 million people worldwide, and it's spread by the air from infected droplets that are spread by coughing, talking, and sneezing. A person breathes in the droplets, and the bacteria settles in the lungs and starts to multiply. From there, the bacteria spread through the blood to other parts of the body, like the kidneys, the bones, and the brain. The immune system responds with inflammation, and then phagocytes engulf and lymphocytes destroy the bacilli and normal tissue in the lungs. This is going to result in exudate, or fluid, in the alveoli, which is going to cause bronchopneumonia. This infection occurs about 2 to 10 weeks after exposure. The masses of live and dead bacilli that have been eaten up by the macrophages, they turn into little granulomas, so like little balls of hard calcium covered balls. And then they become a scar. If the patient has no immunocompromise, meaning they don't have other issues that are making their immune system not respond well, most of the time after we treat the patient, the bacteria becomes dormant and they don't have any more active disease. People who are immunocompromised, we can see the TB come back. Tuberculosis is very hard to completely eradicate. There are several factors that work against our ability to eradicate it. The first is it's still common in foreign countries, and with how easy it is to travel from country to country, we'll never be able to fully get rid of TB. There's no way we can stop it from coming into the country. Another issue is how long it takes to actually detect and report TB. As a new grad, I was caring for a patient with hemoptysis, and everyone assumed that he had lung cancer, and that's what he was being worked up for, and that's what we were about to treat him for. About 6 months later, I got called into HR and occupational health because I had a TB exposure. That patient who had hemoptysis exposed all of us to TB because he didn't have cancer, he had tuberculosis. It took that long for anyone to really determine what he actually had, which is going to bring us to the next point. There's not a great way to protect people who are in contact with TB. In healthcare, we have N95 masks, but in the community, these people are walking around all day long exposing people, and they have no idea they have TB, and they may not know they have TB for months. They might just think they have this annoying cough. There's also a type of TB called latent TB, which doesn't show any symptoms for a long time after infection, so people don't know they're sick, or if they're immunocompromised, they got treated for TB and the TB comes back. Lastly, TB isn't a top priority for public health because it isn't a huge widespread issue. Okay, there's priority on other things like COVID and STDs and other more common public health issues. Risk factors for contracting TB include close contact with somebody who has active TB. The longer you're exposed to the droplets, the greater the risk of inhaling them. People who are immunocompromised, such as cancer patients, HIV and AIDS patients, and those with organ transplants are at higher risk of contracting TB. People living in crowded housing, like colleges, prisons, long-term care facilities, are at higher risk because of the prolonged exposure. And of course, being a healthcare worker puts us at risk. Prevention is really important when it comes to TB so that we prevent outbreaks. The first thing we need to do for this is early identification and treatment of people with TB. If we have a patient who comes in with respiratory issues that have some of the TB criteria, or they have issues going on that can't be explained by other things, we'll test them for TB much faster than we used to do. If the TB test comes back positive, we start them on treatment. We work really hard to isolate people with TB, which is fairly easy to do in a healthcare facility, but if they're out in the community, we can't force them to isolate and stay home. There was actually a case in the news not very long ago where they actually had to arrest a woman with TB because she refused treatment and she refused to isolate. She was just spreading it to everybody. Another thing we do for prevention is surveillance of high-risk people like healthcare workers. There's a screening tool that we have to do every year related to TB, and some facilities do annual TB testing. TB has very classic symptoms. Most of these patients are going to develop a low-grade fever, a cough, night sweats, fatigue, and weight loss. The night sweats and the weight loss should be our biggest clue that this could be TB. The cough they develop may or may not produce sputum. Some patients will have hemoptysis, which is bloody sputum, and these symptoms might be present for weeks or months. This isn't an acute illness like influenza where they're just suddenly sick. In the elderly, their symptoms might not be as drastic, and sometimes they'll have confusion as a symptom. To diagnose tuberculosis, of course, we need to take a good health history and do a good physical assessment. We can do the TB skin test, which is called the Manteau test, where we inject tuberculobacillus extract into their arm and we have them come back 48 hours later for it to be red. There are also blood tests we can do for TB called the quantiferin gold or the T-spot. These results come back in 24 to 36 hours, so those results are quick and they don't require a second appointment like the Manteau test does. We can do a sputum culture to test for the presence of acid-fast bacilli. If it comes back positive, then they might send it for sensitivity to make sure that the TB isn't drug resistant. We can do a chest x-ray, which will show lesions in the upper lobes of those lungs. It'll show those little granulomas. Let's talk a little bit more about this Manteau skin TB test. Although all nurses are trained on how to give intradermal injections, this specific intradermal injection really needs to be done by someone who's been specially trained to do it. Because if we inject too deeply into the dermal space, it's going to void the results. It also needs to be read by someone who is trained. When we do the intradermal injection, we have that patient come back 48 to 72 hours to have that test read. Reading the TB test means it gets checked for redness and induration, and induration is a hard raised area. Both induration and redness must be present, but we're only going to measure the diameter of the induration. We don't measure the redness. The size of the induration determines the significance of the reaction. A reaction of 0 to 4 millimeters is considered not significant or negative. A reaction of 5 millimeters or greater may be significant in people who are considered at risk, and an induration of 10 millimeters or greater is usually considered significant or positive in people who are healthy or have mild impaired immunity. A significant reaction does not necessarily mean that active disease is present in the body. More than 90% of people who are tuberculin significant reactors do not ever develop clinical TB. However, all significant reactors are candidates for active TB, but doesn't mean they're going to get it, but they could. A non-significant or negative skin test means that the person's immune system did not react to the test and that latent TB or an active TB disease is not likely. Medical treatment of TB consists of anti-tuberculosis medications for 6 to 12 months. This is to fully kill the bacteria and prevent recurrence. Remember, the body's going to form granulomas around the bacteria, and those are hard like calcium. It takes a lot to get through that calcium to kill the bacteria inside. Unfortunately, a lot of people don't want to take the medications for this long, or they can't afford it. So we have a lot of drug-resistant strains to tuberculosis. Some are resistant to multiple drugs, and some are resistant to most drugs. Because of this, when we treat TB, we always give them 4 or more first-line medications. That means they're taking 4 medications at one time. There are several first-line medications that can be used, and these include isoniazid, rifampin, pyraxenamide, rifabutin, rifapentine, ethambutol, and a combination of medications such as NIH and rifampin might be used. The combination drugs are awesome. It's true medications in one pill, but they can have some significant side effects being a combination drug, and they're extremely expensive. as a combination drug. I will say that all of these first-line treatments have very significant side effects, and they can all negatively affect the liver. So that means in addition to paying for the medications, they're also paying for frequent lab draws to check their liver. When we give these medications, we give it in 2 phases. The initial treatment lasts about 8 weeks, and then we do a continuation phase for about 4 to 7 months afterwards. If we have a person who's at significant risk for contracting the disease because they were exposed to TB, we will prescribe them prophylactic anti-tuberculosis medications for 6 to 12 months to prevent the disease from actually occurring in their body. And then if our patient has multiple drug-resistant tuberculosis, it's even harder to treat. The treatment is going to be guided by the sputum specimen culture and sensitivity. So we'll wait for that culture to come back to tell us what medications are going to work for that specific tuberculosis strain. Usually, if we see multi-drug resistant tuberculosis, they're going to be resistant to that isoniazid or rifampin or both. And this means that 2 of our first-line drugs don't work. So we're actually going to have to give a combination of 3 to 5 second-line drugs. And that's part of the recommendation. So now we're giving them more medication. Example of these second-line drugs include aminoglycosides, fluoroquinolones. We can give them capreomycin, ethanolamide, oh my goodness, one I can't say, para-aminosalicylic acid sodium, and cycloserine. So not only are they getting more medications, they're getting more side effects and more cost. Nursing management of tuberculosis includes promoting airway clearance, encouraging adherence to medication, promoting activity and nutrition, and preventing transmission. People with tuberculosis can have copious amounts of secretions that can sometimes interfere with gas exchange. These patients need to increase oral fluids to help loosen those secretions and may need to sit and cough in certain positions to help drain the secretions. And we call this postural drainage. Nurses do a lot of education and encouragement to help these patients adhere to their medication regime and their treatment plan. These medications have significant side effects and costs, so many people want to stop taking the medications before the bacteria is fully eradicated. They also have to follow a specific schedule for the medications. If they don't follow the medications schedule, they will lead to more drug-resistant strains of tuberculosis, and of course, it's going to cause the patient to not be fully cured. The patient also needs to adhere to their lab tests, checking for liver functions and any repeat sputum cultures that they need. People with tuberculosis are sick and they're oftentimes malnourished. They can become so fatigued just from the work of breathing that they can't eat enough calories to maintain their weight, so they lose incredible amounts of weight. This causes them to be more fatigued. The cost of the medication may also cause the person to have to choose between food and medication. If we can keep the person nourished, we may be able to get them to start a small amount of activity, which may also help them clear their secretions easier. Lastly, nurses do a tremendous amount of education related to the transmission of tuberculosis and how to prevent transmission. This is going to include hand hygiene, hand washing, safe coughing and sneezing, and reporting contacts to the health department. Valley fever, or coccidiomycosis, is a fungus that's found in the southwest United States, like Arizona. These fungi are commonly found in the soil and get stirred up by the wind, construction, or farming. Humans then breathe in the fungi and it gets trapped in the lungs and causes illness. The acute form of valley fever causes fever, cough, fatigue, shortness of breath, headache, chills, muscle and joint pain, and sometimes can cause a rash on the legs, arms, and back. This can be mistaken for a cold or the flu, and some people don't even get symptoms, so they don't even know they had valley fever until they have an unrelated chest x-ray or they have a lab test. Unfortunately, this disease can take weeks to months to fully recover from, and it can become chronic. Usually the people who develop chronic valley fever were already immunocompromised. Preventing this disease is really going to help people stay away from moving dirt. Wearing a mask when they're digging or doing construction, wetting down the soil before they start digging, and staying inside during dust storms and keeping their windows and doors shut if they're at high risk are really going to help prevent this. And the diagnosis of valley fever is going to be made on history and symptoms, along with a sputum culture or an antibody test. We can do a blood antibody test. X-rays can be used, but X-rays can't differentiate between valley fever and pneumonia. Treating valley fever usually doesn't occur unless the symptoms are lasting a long time or getting worse. The first line of treatment is with antifungals like fluconazole or diflucan for 3 to 6 months. Fluconazole can cause nausea, vomiting, stomach pain, and diarrhea. If the fluconazole doesn't work, or if the disease is severe, the next line of medication is amphotericin B IV. This drug is nicknamed amphoterrible because it has horrible side effects like fever, chills, anorexia, hypotension, kidney damage, hypokalemia, wheezing, and dyspnea. People can end up in kidney failure and dialysis from amphotericin, and I consider this one of my kidney killers. We also want to treat the symptoms just like we did with the common cold, influenza, and COVID. And these people really need to rest. Valley fever can make people very winded very easily, and they need to rest. And this is the end of respiratory.